Hello everyone, this is Joanne and welcome to my YouTube channel. So today we will be discussing about nutrition and fluid therapy. So in this module we will be learning about the causes and consequences of malnutrition in the surgical patient, the fluid and electrolyte requirements in the pre and post-operative patient, the nutritional requirements of surgical patients and the consequences of intestinal resection, and the different methods of providing nutritional support and their complications. So these are the topics we will be discussing. Now, as we all know that malnutrition is common, okay? So it occurs in about 30% of the surgical patients with GI disease and in up to 60% in whom the hospital stay has been prolonged due to post-operative complications. So in this image, you can see a severely malnourished patient with wasting of fat and muscle. So this is a case of long-standing protein calorie malnutrition. So that is easily identifiable. However, in short-term undernutrition, it is less easily recognized. And this occurs in critical illness, major trauma, burns or surgery, and it also impacts the patient recovery. So we have to identify these patients who are at risk of malnutrition, and we have to ensure that the nutritional requirements are met by the most appropriate route and in a way that minimizes the complications. So now we're going to talk about the metabolic response to starvation. So in short-term starvation, what happens is that the plasma insulin level will fall. So in less than 12 hours of starvation, plasma insulin level will start to fall and plasma glucagon level is starting to increase. So this will stimulate the hepatic production of glucose from glycogen. So it results in hepatic glycogenolysis and it will also result in protein catabolism. Okay. After that, in starvation greater than 24 hours, so what will happen is that the glycogen stores are now depleted. And now what will happen is gluconeogenesis. So hepatic gluconeogenesis will take place. So you can see there glycogen stores are depleted. Gluconeogenesis will take place predominantly in the liver. Now what happens after that? Lipolysis. So lipolysis will happen with more prolonged fasting. There is an increased reliance on the fat oxidation to meet the energy requirements. So fat stores are mobilized. Fat oxidation is increased. Then what happens is ketogenesis. So hepatic production of ketones from fatty acids is facilitated by the low insulin levels. And after the 48 to 72 hours of fasting, the brain, the CNS, will also adapt to using ketone bodies as their primary fuel source. So that is how the response of our body to starvation is. Okay, this is what we discussed. And then there is a reduction in the resting energy expenditure. So 25 to 30 kilocal per kg per day. From that, it is reduced to 15 to 20 kilocal per kg per day. So that is how our body responds to starvation. So now we're going to discuss about the nutritional assessment. In laboratory techniques, we will check the biochemical measurement. So there is no single biochemical measurement that will reliably identify malnutrition. Albumin is not a measure of the nutritional status, particularly in the acute setting. So a low serum albumin, that is less than 30 gram per liter, is an indicator of poor prognosis, but pre-albumin is a better indicator. Because like hypoalbuminemia, it can occur in the cases such as alteration in body fluid composition and because of increased capillary permeability, which is related to ongoing sepsis. So in those cases also there can be hypoalbuminemia. So pre-albumin is a better indicator, and we also can take a measurement of the lymphocyte count because immune status will also be defective in these patients. Now body weight and anthropometry. The best method, a simple method of assessing nutritional status is to estimate the weight loss. So we can compare the measured body weight with the body weight from the tables. So unintentional weight loss of more than 10% in the past 6 months. This is a good prognostic indicator of poor outcome. Alright, so weight loss more than 10% in the past 6 months. is an indicator of poor outcome. Also, we can check the BMI. So BMI less than 18.5 means nutritional impairment, and below 15 it is associated with significant hospital mortality. So we can say BMI less than 15 is also associated with poor outcome. All right. So weight loss is in 6 months we are taking. Okay. Next we have the anthropometric techniques. So we incorporate the skin fold thickness, all right, and the mid upper arm circumference. So skin fold thickness is an estimation of the body fat, and mid upper arm circumference will give us an estimate of the muscle mass. So these are the anthropometric techniques. Now clinical examination. So in this we have something known as the MUST screening tool. So this is introduced by the British Association of Parenteral and Enteral Nutrition, and this is a 5-step screening tool to identify adults who are already malnourished or at risk of undernutrition. And let's look at it in detail. So what are the components of this MUST tool? We have the BMI, the body mass index, okay, weight loss score, and acute disease effect score. So step 1 is the BMI score, step 2 is the weight loss, and step 3 is the acute disease effect score. So in BMI we have 0, that is more than 20 kilogram per meter square. 1 is 18.5 to 20, so that is 20, not 2.0, that is 20, and 2 will be less than 18.5. So that is how we calculate the BMI score. Now weight loss in 3 to 6 months, we check for the weight loss in 3 to 6 months, and less than 5% means we give a score of 0, 5 to 10% means we give a score of 1, and greater than 10% means we give a score of 2. Now acute disease effect, so we add a score of 2 if there has been or is likely to be no or very little nutritional intake for more than 5 days. So these are the 3 steps in the MUST tool. Okay, now we add the scores. There is a step 4 is the adding, and then we check the overall risk of undernutrition. So 0 means low, 1 means medium, and 2 or more means high. So if it is 0, then we repeat the screening. So if it is in a hospital every week, care homes every month, and community every year. Medium means observe, so hospital document dietary and fluid intake for 3 days. Care homes just as for the hospital, and community means repeat the screening. And 2 or more means high, so treat the patient. Hospital, refer to the dietitian and implement the local policies. Generally food first followed by food fortification and supplements are given. Care homes means as for the hospital itself, and community also as for the hospital. So that is our malnutrition universal screening tool. Now for all the risk categories, we have to treat the underlying condition and provide help and advice on food choices, eating and drinking when necessary. Also record the malnutrition risk category and record need for special diets and follow the local policy. Reassessment has to be done. So if the patient is obese, we record the presence of obesity, and for those with underlying conditions, these are generally controlled before the treatment of obesity. So now we're going to discuss about the fluid and electrolytes. So let us look at this table from Bailey. Alright, so this talks about the average daily water balance of a healthy adult in a temperate climate. So the output and the intake. So urine output is 1500 ml. Insensible losses will be 900 ml, and feces 100 ml. Intake, water from beverage 200 ml, water from food 1000 ml, and water from oxidation 300 ml. So these are the values. So the prescription of maintenance fluids, it should aim to restore the fluid losses. It should also aim to provide sufficient water as well as electrolytes to maintain the intracellular and the extracellular fluid compartments. It should also enable the kidneys to excrete the waste products. So we have to give maintenance fluids in such a way that all this is taken care of. Alright. So let me just write it down. It should restore the losses. It should maintain the intra as well as the extra cellular compartments. And it should enable the kidneys to excrete the waste products. So the normal volume of water which is required for daily maintenance in a healthy adult, 70 kg adult, is approximately 2.2 liters or 30 ml per kg per day. Alright, now let us look at the electrolyte requirement. Approximate daily electrolyte requirement: sodium is 0.9 to 1.2 millimole per kg per day, potassium 1 millimole per kg per day, calcium 5 millimole per day, magnesium 1 millimole per day. So that is the daily requirement. Just take care of the units. Okay, so yeah. So the replacement of fluid and electrolytes should be by the simplest and safest route of administration. Also, the specific type of fluid replacement therapy will be determined by the individual patient's needs. So commonly used IV fluids, as you can see here, these are important to remember: 0.9% NaCl, dextrose in 5% water, and Hartmann solution. Also, these are crystalloids. This can be replaced by colloid solutions. Now, the examples for colloid solutions are gelfusin, Volplex, and Voluven. Okay. So I'm just highlighting the stuff from the textbook. You can see that for those who are reading the textbook alongside with the watching the video, just highlighting the stuff here. So a typical daily maintenance fluid regimen would consist of a combination of 5% dextrose with either Hartmann's or normal saline to a volume of 2 liters. So here in table 19.2 we have the composition which is important. So Hartmann solution: sodium 131 millimole per liter, potassium 5, calcium 2, chloride 111, and lactate 29. Normal saline means sodium 154, chloride 154. Dextrose saline, sodium 30, potassium 30. And these gelfusin, hemacil, and hetastarch, they are the colloids. Now we're going to talk about the nutritional requirements. So total enteral or parenteral nutrition. So we have two types of nutrition, that is enteral nutrition and parenteral nutrition. And whatever is the type of nutrition we're giving, what is the mode of nutrition we're giving, whatever that is, when planning a feeding regime, the patient should be weighed and an assessment made of the daily energy and the protein requirements. So we have to do that in order to avoid overfeeding, because overfeeding is one of the most common cause of complications. Alright, so we have to plan a feeding regime and we have to monitor the feeding regime. So let us discuss the recommended schedule for monitoring the feeding regimens. So what do we do? Now daily observations including pulse, BP, temperature, body weight, fluid balance including volume of urine and urine and intestinal losses, quantity and type of food consumed if allowed to eat, plasma levels of sodium, potassium, urea, creatinine, blood glucose, magnesium and phosphate if the patient is at risk of refeeding syndrome, which we will discuss later on, liver function test and C-reactive protein. Now these are the things which we check for on a daily basis. Alright, pulse, body weight, fluid balance, quantity and type of food, sodium, potassium, magnesium, phosphate, liver function test, C-reactive protein. Weekly to fortnightly we check the full blood count, calcium, zinc, copper, plasma proteins including albumin, thiamine, triglycerides, vitamin B12 and folic acid. 3 to 6 monthly we have to check the ferritin, we have to check the selenium and manganese, and 25 hydroxy vitamin D. So once the patient is established on a stable feeding regimen, we can check these plasma levels that we check on a daily basis, on a weekly basis now. So now looking at the macronutrient requirements. Energy requirement. So total energy requirement of a stable patient, 20 to 30 kilocal per kg per day. And very few patients require energy intake in an excess of 2000 kilocal per day. But otherwise, this is the average energy intake. Okay. Now, carbohydrate equivalent of 2 gram per kg of glucose per day. Alright. As you can see here, 2 gram per kg of glucose per day. the dietary guidelines therefore recommend that the carbohydrates form around 45 to 65% of the total calorie intake per day. So that is the caloric intake per day. Now, seeing that in the textbook, it is written the obligatory glucose requirement to meet the needs of the central nervous system in certain hematopoietic cells, which is equivalent to about 2 gram per kg per day. Yes, that is the around 45 to 65% of the total caloric intake. So about the protein, so the daily nitrogen requirement in an ill patient, okay, it increases from 0.15 gram per kg per day to 0.25 gram per kg per day. Writing it down, 0.15 gram per kg per day to 0.25 gram per kg per day. Now this is like 1.5 gram per kg of protein, right? And it is around 20% of the total energy requirements. This is in order to reduce the nitrogen losses at the time of illness. Now talking about the fat requirements, so emulsions of long chain triglycerides are now being used as parenteral nutrition. So this is a mixture of glucose and fat. So glucose is given a minimum of 100 to 200 gram per day, and fat 100 to 200 gram per week is delivered. Alright, next is about the vitamins, minerals and the trace elements. So vitamin C requirement in the post-op period will increase to 60 to 80 milligram per day. Now supplemental vitamin B12, it has to be given especially in patients who have undergone intestinal resection or gastric surgery, and in those patients with a history of alcohol dependence. Okay, so fat soluble vitamins A, D, E and K are not absorbed in case there is a reduction of pancreatic or biliary enzymes in the intestinal tract, and this is associated with some medical condition or a surgical procedure which resulted in the reduction of these enzymes. Okay, and these are the important points that I've highlighted. So first is the vitamin C requirement increase 60 to 80 mg per day, supplemental vitamin B12 and the malabsorption of the fat soluble vitamins. Increased intestinal losses such as in chronic diarrhea, it can cause hyponatremia, hypokalemia and hypophosphatemia. Also trace elements such as magnesium, zinc and iron, they are important cofactors in metabolic processes, and these cofactors, they may be reduced as part of inflammatory response. So let us discuss about the fluid and nutritional consequences of intestinal resection. Now up to 50% of the small intestine can be surgically removed or bypassed without permanent deleterious effects, But extensive resection, that is less than 150 centimeter of remaining small intestine. This will lead to metabolic and nutritional consequences and is known as short bowel syndrome. So it results in something known as short bowel syndrome. Okay, so this clinical presentation will depend upon the site and the extent of the intestinal resection. Now, the small bowel motility, it is 3 times slower in the ileum than in the jejunum. Okay, so in addition, the ileocecal valve will slow down the transit. So it receives endogenous secretions as well as exogenous fluids per day, and most of this is reabsorbed in the small bowel. Alright, so just note that it has been estimated that the efficiency of water absorption is 44% of the ingested load in jejunum and 70% of the ingested load in ileum. And for sodium, it is 13% and 72% respectively. So ileum plays a major role in the conservation of fluid and electrolytes. That is what we have to take away from these points. Now, ileum. So ileum is the only site of absorption of vitamin B12 and bile salts. So bile salts we need it for the absorption of fats and fat soluble vitamins, as we already know. Alright, so and the enterohepatic circulation is critical to maintain the bile salt pool. So after the resection of the ileum, this is not met. So loss of bile salts will increase, okay, and the synthesis will not meet the demand also. Now depletion of bile salt pool will result in what? Fat malabsorption. And also what happens? The colonic mucosa is affected because the bile salts are lost into the colon, and that will result in increase the stool losses of the salt and water. Now colon. So colon transit times in the colon vary between 24 and 150 hours, and the efficiency of water and salt absorption exceeds 90%. Okay. Another important function is that it ferments the carbohydrate and forms short chain fatty acids. Alright. So effects of resection. We're going to look at the effects of resection. So resection of the proximal jejunum will result in no significant alteration in fluid and electrolyte levels because the ileum and colon can adapt to absorb the increased fluid and electrolyte load. So ileum and colon will make up for the loss of function of the jejunum. So resection of the ileum but will result in significant enhancement of the gastric motility and acceleration of the intestinal transit. So after the resection of the ileum, what will happen? The colon will receive a larger amount of the fluid and the electrolytes. It will also receive the bile salts. Now this will reduce its ability to absorb the salt and water, resulting in diarrhea. So resection of the ileum result in increase in the gastric motility. Alright, and it will result in acceleration of the intestinal transit, also resulting in diarrhea. And even the loss of 100 centimeter of the ileum may cause steatorrhea. So this will necessitate the administration of the cholestyramine to bind the bile salts. So there is steatorrhea. And with larger resections greater than 100 centimeter, dietary fat restriction is required and regular parenteral vitamin B12 should also be given. So we talked about less than 100 centimeter resection, we talked about more than 100 centimeter of ileum resected, and now most challenging patients are with those who have excess of 200 centimeter of the small bowel resected along with the colectomy. So these people will have jejunostomy, okay, and they are conveniently divided into two groups, net absorbers, net secretors. We will not be going into detail of that, but you just have to read this portion. It is easy. And now we go into the complications of the short bowel syndrome. So that includes peptic ulceration, which is due to the hypersecretion of gastric acid, cholelithiasis because of interruption of the enterohepatic cycle of the bile salts, and hyperoxaluria, which is due to increased absorption of oxalate in the colon, and this will predispose to formation of renal stones. So the complications of the short bowel syndrome include peptic ulcer, which is due to increased gastric secretion, cholelithiasis due to interrupted enterohepatic cycle of the bile salts, hyperoxaluria because of increased absorption of the oxalate. This will predispose to renal stones. In some patients with short bowel syndrome, they can develop a syndrome of slurred speech, ataxia, and altered effect. So why is this? This is because of the fermentation of these carbohydrates which are not absorbed completely. Alright, in the colon, I told you the colon, one of the function is to ferment carbohydrates into short chain fatty acids, I told you. So this will happen. So the treatment is to give a low carbohydrate diet, and we can give anti-secretory drugs, okay, so we can reduce the amount of fluid secreted from the stomach, liver, and pancreas. Okay, this will include the H2 receptor antagonist, proton pump inhibitors, and the somatostatin analog octreotide. So we have the H2 receptor antagonist, proton pump inhibitors, and somatostatin analog octreotide. So octreotide will reduce the gastric motility, proton pump inhibitors will lower the gastric pH. Alright, so that is its function. Now the anti-motility drugs can also be given. Example, we know commonly what we give, loperamide. Okay, so this will decrease the water and the sodium output from the stoma by about 20%. So now we're going to talk about artificial nutritional support. So in what patients do we give artificial nutritional support? We all know that it is in patients who have difficulty consuming any or sufficient oral nutrition. So artificial nutritional support should be given in any patient who has had inadequate nutritional intake for 5 days or more. So we're giving it in patients who have had inadequate nutritional intake for 5 days or more. So what are the ways in which we can give artificial nutritional support? We can give it as enteral nutrition, or we can give it as parenteral nutrition. Alright, so enteral is via the gut and parenteral is via the IV route. Alright, and which is better? Enteral is better than parenteral. Now why is enteral better than parenteral? Because as we know, enteral is a physiological way, right? It is physiological. So the first point is that it is physiological. Not only is it physiological, it is cheap. Alright, and it maintains the enterohepatic circulation. So it will also maintain the microvilli. Alright, and it will prevent the translocation of the gut bacteria. So we also have an advantage, which is prevention of gut atrophy. So look at this image. So here you can see the routes available for the delivery of artificial nutritional support. There is parenteral nutrition, total parenteral nutrition, partial parenteral nutrition. We will go into its detail. There is nasogastric or duodenal or jejunal tube. You can see it is inserted through the nose. Gastrostomy tube, jejunostomy tube, and whole food by mouth, which is the best route. So we know oral is the best route. Now if the patient cannot take food orally, what will we do? We opt for other modes, other routes. So we have, based on the duration of requirement, less than 2 to 3 weeks means we can either use a Ryle's tube or a nasogastric tube. Alright, and we can also give nasojejunal feeding. So when do we give nasojejunal feeding and when do we give Ryle's tube? So if there is good gastric emptying, okay, then we opt for Ryle's tube or nasogastric feeding. Okay, and if there is poor gastric emptying, we opt for nasojejunal feeding. Now if it is more than 2 to 3 weeks requirement, then we go for feeding gastrostomy or feeding jejunostomy. Again, based on whether there is good gastric emptying or poor gastric emptying. So good gastric emptying, feeding gastrostomy. Poor means feeding jejunostomy. We have good gastric emptying for less than 2 to 3 weeks duration, Ryle's, and poor gastric emptying less than 2 to 3 weeks duration, we have nasojejunal feeding. Okay, and more than 2 to 3 weeks duration, we are feeding gastrostomy and feeding jejunostomy. Moving on to the details. So patients who are unable to maintain adequate nutritional intake with the oral supplements will need administration of the enteral feed via the tube feeding. A conventional nasogastric tube, Ryle's tube or fine bore feeding tube can be inserted into the stomach. Or we can do it via surgical or endoscopically placed gastrostomy. Now, the patient's nutritional requirements have to be met. So we need a trained dietitian because we have to assess the patient's nutritional requirement. So we have to gradually increase the rate of feed. So it typically starts at 10 to 20 milliliter per hour, and we can increase approximately to 75 milliliter per hour if it is tolerated. So this point is important. This is one of the principles of enteral nutrition, that we have to start it at 10 to 20 milliliter per hour and then increase it to approximately 75 milliliter per hour if tolerated. What we also should take care of is that the aspirate. So we have to aspirate before a subsequent meal and see if the aspirate volume is more than 75 to 100 cc. If that is the case, if it is more than 75 to 100 cc, then we will withhold the subsequent meal, because if the feeding is increased, so there can be over distension of the stomach and there can be aspiration. So to prevent that, we will always aspirate and see for the volume of the feed. So discussing the techniques for establishment of tube feeding. So NG tubes can usually be inserted in the ward setting, but in patients with concerns regarding the anatomy of the oropharynx or esophagogastric anatomy, endoscopic insertion under direct visualization is needed. Patients are in semi-recumbent position and the distance between the siphisternum and tip of nose is measured. So tip of nose to the ear lobule to the siphisternum. So this is the length of the Ryle's tube. This is the length of the Ryle's tube that we'll be using. Now the tube is inserted into the nose and it is advanced to the 10 centimeter point. Now the patients are asked to swallow and the tube simultaneously goes down the esophagus with successive swallows until the distance measured to the siphisternum is reached. Now we will also check the position of the nasogastric tube. So we have to check it before the feed is administered. We can take a chest radiograph, we can do pH testing. So now feed can be directly delivered into the jejunum via tube feeding or surgically created jejunostomies. So the advantage of this, it bypasses the stomach and we can overcome the problems of delayed gastric emptying. So if there is delayed gastric emptying, patient will have nausea, vomiting. So in that case, without starting TPN, we can go for nasojejunal feeding. We can also go for nasojejunal feeding in patients who are unable to have a gastrostomy. So we can either insert it endoscopically or radiological, fluoroscopically. So it cannot be inserted in the ward setting. So now let us discuss about gastrostomy. So this is for patients who require longer term feeding. I told you more than 2 to 3 weeks. And this is for patients with good gastric emptying. So the tube is directly inserted into the stomach, as you can see in this picture. So gastrostomy insertion can be endoscopic, PEG, percutaneous endoscopic gastrostomy. Okay. So it can be endoscopic. Radiological means radiologically inserted gastrostomy or surgical. So you can see here in this picture, this is percutaneous endoscopic gastrostomy. So PEG will involve the insertion of the gastrostomy tube through the abdomen and stomach under the vision of an endoscope. So you can avoid a surgical incision under general anesthetic. Now about RIG. So RIG is an option in the patients who are unable to have a PEG because of difficulty of esophageal intubation, compromised respiratory function or oropharyngeal anatomy, distortion such as from head and neck cancers. So in those patients, we give RIG. Now complications of gastrostomy include perforation, bleeding, peritonitis. They can be localized sepsis around the site of insertion and this will require systemic antibiotics. Now talking about the jejunostomies. So this is created at the time of resection in those patients who are undergoing some major esophagogastric surgery and they are likely to have insufficient oral intake in the immediate post-op period. So we require a general anesthetic and a laparotomy, a laparoscopy So the feeding tube is inserted through the anterior abdominal wall directly into the proximal jejunum, as you can see in this picture. So now discussing the complications of enteral feeding. So the complications of enteral feeding, you should learn this table. So we have the tube related complications. We have the gastrointestinal complications, metabolic or biochemical complications. What all comes in tube related complication? There can be malposition of the tube. There can be displacement of the tube, blockage of the tube, breakage or leakage of the tube, and local complications such as there can be erosion of the skin or mucosa. So malposition, displacement, blockage, breakage, and local complications. In GI, what are the diarrhea can be there? So here you can see it is written that the enteral feeding is not appropriate in patients who are not likely to absorb the delivered nutrients. So in these patients who have short bowel syndrome, that is the length of the function intestine is insufficient. Alright, they cannot absorb these delivered nutrients. So in these patients with short bowel syndrome, mechanical intestinal obstruction, paralytic ileus, they will require TPN. We will learn this in the indications for TPN. But I am saying this now because the GI complications will include bloating, vomiting, diarrhea. See, abdominal cramps, aspiration and constipation. So writing down diarrhea, vomiting and so on. So we have the rest also. Now metabolic complications, these are due to the feeding. So we have to monitor the feeding carefully because rapid increase in the nutrient delivery can also lead to something known as refeeding syndrome in chronically malnourished patients. When you suddenly give nutrition in large amounts, it can result in refeeding syndrome. So now let us discuss about parenteral nutrition. So what are the indications for parenteral nutrition? So one is prolonged paralytic ileus. So paralytic ileus means the propulsive function is lost, paralytic. So more than 72 hours. Then we have short bowel syndrome. So these patients, they are unable to absorb the nutrients from the intestinal tract. So it can be related to a massive intestinal resection or a significant reduction in functional small bowel. So short bowel syndrome. Then we have high output fecal fistula. Then we give parenteral nutrition in acute episodes of IBD. We also give parenteral nutrition in the initial phase, not the initial phase of severe acute pancreatitis. So now what is the mode of administration? So the best route is a central line. We have also a peripheral IV line. So central line is the best route, and we have the peripheral IV line, which is the least preferred route. Why is this the least preferred route? Now this is because of increased risk of thrombophlebitis. Therefore, this is the least preferred route for administration of parenteral nutrition. We also have something known as the PICC line. So that is peripherally inserted central catheter. Now, which is the most common vein used? That is IJV, internal jugular vein, is the most common vein used overall. But for TPN, most common used vein is subclavian vein. So subclavian vein, there is the least risk of infection. And femoral vein, there is the maximum risk of infection. Internal jugular vein, it is lies somewhere in between, right? So here in the text also you can see it's written femoral lines should be avoided for parenteral nutrition because of high risk of infection at this site. Now in terms of pneumothorax, just imagine the location of subclavian vein and you can understand, so the maximum risk of pneumothorax is with the subclavian vein. Alright. And for with the femoral vein, it is like really hard to create a pneumothorax, right? So there is least or no risk of pneumothorax with the femoral vein. And internal jugular vein, it is common. Now, ease of insertion, it is maximum with the internal jugular vein. That is why overall most common used vein is internal jugular vein, but in TPN it is subclavian. See here in this image you can see an example of a central venous line, subclavian line, alright, which is used for the administration of parenteral nutrition. So here is a chest radiograph. So we take a chest radiograph. So here in this chest radiograph, it shows the internal jugular and the PIC lines within the superior vena cava. Also observe the NG tube and the NG tube, right? Now talking about TPN. So we give an amount of 1 to 2 liters over 24 hours. What is the composition? So we have 3 in 1 and 2 in 1. Okay, so here you can see this, right? TPN, this bag. So 3 in 1 means we have protein, fat and carbohydrates. Alright, so protein 20, fat 30, carbohydrate 50. So 20 is to 30 is to 50. This is the ratio. We also have trace elements, vitamins. Okay, these can be added. But what is missing here in this TPN solution that we give is fibers. So there is no fiber. So there is 3 in 1. All the 3 components are there. 2 in 1 means only fat and carbohydrates is there. So what are the complications of parenteral nutrition? So we have to consider insertion complications, line complications and metabolic complications. So in insertion complications, what do we have? We have pneumothorax. We have misplacement. So pneumothorax is the one of the insertion complications. So this is most commonly during insertion of subclavian lines, as I said earlier. Now line misplacement can also occur. This is diagnosed on a chest radiograph. Okay, so this is mandatory following central line insertion to take a chest radiograph. So those were the insertion complications. Now line complications. So the most common complication is line sepsis. So catheter related sepsis. So this can occur in up to 15% of the patients, and it is associated with significant morbidity and mortality. And in those patients with suspected line sepsis, what do? We take paired blood cultures from the line and from a separate peripheral site. And then the line use should be stopped until the culture results are available. So if the culture is positive, then we will require a line removal and we have to commence antibiotics. So next is thrombosis. So this is also not uncommon. So this can occur in the major veins in association with line infection. Okay, and it can cause some serious complications such as SVC occlusion, pulmonary embolism. So we treat it by anticoagulation. Now discussing the metabolic complications, in that we have the most awaited refeeding syndrome. So I've been mentioning this particular times in this chapter, right? So refeeding syndrome is something that occurs in severely malnourished patients. On starting TPN in the first few days, right, after feeding, due to the excessive amount of feeding, right, this particular complication occurs. So it is in severely malnourished patients. So these patients, they shift from a catabolic state to an anabolic state. Right, severely malnourished to now they are kind of being overnourished if there is overfeeding, right? So then what happens, that there is a release of insulin and then there is uptake of these electrolytes such as potassium, magnesium, calcium and phosphate. Now what will happen is that it will result in hypophosphatemia, it will result in hypokalemia, it will result in hypocalcemia, and it will result in hypomagnesemia. Now what will happen is that this can lead to arrhythmias, it can lead to cardiac failure, it can also be fatal. So that is what refeeding syndrome is all about. See, here is a potential MCQ question. Here it's written the main underlying pathological process is one of hypophosphatemia. So note that this resulting in fluid and electrolyte shifts between the intra and extracellular compartments. So patients can develop congestive cardiac failure, they can develop arrhythmias, and they can develop edema, and they can even it can even be fatal. So another complication that we have is hyperglycemia. Right, now liver dysfunction. So long-term use of TPN is associated with derangement of liver function tests in at least 25% of the patients. Fatty liver is a common complication, worse in children, right? Also, small percentage of people, they develop liver fibrosis, cirrhosis. Now, once this liver disease is established in these patients, we use the term intestinal failure associated liver disease. So that is it about liver dysfunction as a complication of TPN. Metabolic bone disease also occurs, osteoporosis and osteomalacia. They are both known complications of long-term parenteral nutrition. So it can lead to fractures or kidney stones. Alright. This is our entire chapter. I tried to explain it as best as I could. Now let us discuss some MCQs. So, which of the following is the most common complication of TPN? Catheter-related complications, acidosis, acalculous cholecystitis, hypokalemia. Most common is catheter-related sepsis. Alright. This is the most common complication. What is the most dangerous complication? The most dangerous complication? Yes, it is a pneumothorax. So the answer to this question is catheter-related complications. Let us look at the next MCQ. Which among the following is the best method to assess intake of fluid in polytrauma patients? So A is urine output, B central venous pressure, C pulse, and D BP. What is the answer? So the answer is A, urine output. What is the normal urine output in an adult? So the normal urine output in an adult is 0.5 ml per kg per hour. Alright. So next question. Best vein for total parenteral nutrition is A subclavian vein, B femoral vein, C brachial vein, D saphenous vein. The answer is subclavian vein, right? So why is subclavian vein the best for total parenteral nutrition? Yeah, femoral vein is most risk of infection and subclavian vein has the least risk of infection. Alright, yeah, this was already discussed. And the subclavian vein, however, has maximum risk of pneumothorax. Yes. Now the final question. In surgical patient, malnutrition is best assessed by? The answer is mid-arm circumference. Alright. This is the end of the module. I want to remind you that you're all special and you can do anything you put your mind to. So stay tuned for more of my videos. Like, subscribe and share to all of your friends. Thank you.